My name is Austin Ritzel, Director of Advisory and Communications at 17 Asset Management. Much could be said about the accomplishments of our guests today, but because we have a paucity of time and an excess of brilliant minds, I'm going to keep introductions short. In that vein, our next panel will discuss innovative business models in Asia that are disrupting traditional healthcare pathways. This panel will be led by Faye Sahai, founder of Mirai Global and founder and partner of Telosity Ventures. Ms. Sahai is an innovation leader and investment advisor on strategy and startups with a strong emphasis for innovation and healthcare. She is thus perfectly suited to lead this discussion. Please take it away, Ms. Sahai.
Thank you, Austin. Welcome, everyone. I'm so excited to talk to our esteemed panelists. They're leaders, operators, and founders of inclusive healthcare businesses in Asia. They'll be sharing their market cases and their return-driven business models for inclusive healthcare businesses in Asia. As we've heard from the previous panel, there's wonderful opportunities, but also challenges and barriers as well. So I'd like to introduce Viren, Vice Chairman of Narayana Health, Snehal Patel, co-founder and CEO of MyDoc, and Keith Wallace, Chief Technology Officer of Praava Health, and Seth Zhang, founder and CEO of MediTrust. Welcome to the panel here, to our esteemed panelists. I would love to first start off with them giving a quick intro of themselves from that standpoint. And Viren, can we start with you?
Sure. Good morning and good evening, everyone. My name is Viren Shetty. I'm the Vice Chairman of Narayana Health. We're a group of hospitals based in India, and we also run a hospital in the Cayman Islands. Our group is not the original founder of low-cost healthcare in India. There were many that brought that in, but we were the first to have to adopt that at scale. In India, most healthcare is served by the private sector. And so it's very important for us when patients are coming and paying out of pocket, that would be extremely cost efficient. And so we've applied business practices from multiple industries to try and reduce the cost of delivering healthcare and bringing in efficiencies. And we're looking forward very much to a few digital innovations that we hope will be able to scale even further than we have before.
Viren, thank you. It's so wonderful to kind of see that low-cost healthcare at scale and how it can be replicated and grow. Snehal, do you want to go next and talk about MyDoc?
Certainly. It's a pleasure to be here. Thank you, ladies and gentlemen, for taking time today. So my name is Snehal Patel. I'm the CEO and co-founder of MyDoc. We are a digital health platform that is now across 7 markets in South and Southeast Asia. Our go-to-market is really around providing cost-effective telemedicine-driven engagements for users. We work really closely with a lot of the payers in the markets in which we're active. We've been around for almost 7 years. And so we started, I think we were one of the first companies in the region to launch a telepharmacy link with a large local pharmacy chain, as well as with an insurer in all of Southeast Asia, in fact. So that our mission really is to help that transformation from a fee-for-service world into more of a value-based care approach.
Wonderful. Great to see the telehealth, the telepharmacy, and value-based care. Keith, would you like to introduce yourself as well?
Good morning, good afternoon, good evening, everyone. My name is Keith Alwis. I'm Chief Technology of Praava Health. Just a little bit about us. We're what we describe as a brick and click integrated outpatient model of care. We're located in downtown Dhaka, the capital city of Bangladesh, and we essentially offer a range of clinical services, mostly around primary and secondary care, including things like family doctors, women's health, dentistry, ophthalmology. We also have 6 in-house labs offering a range of imaging services and an in-house pharmacy as well. On top of that more traditional bricks and mortar, we offer a digital layer of care that sits over the top of it. Things like virtual primary care, e-pharmacy, sits across this kind of physical and bricks and mortar. Pleasure to be here.
Wonderful, Keith. Wonderful to have you as well. And I love the bricks and clicks of what you're developing there. Seth.
Okay, thanks. Hi, everyone. Good day. And my name is Seth. I'm the founder and the CEO of MediTrust. We found like 5 years ago, actually, we are the largest health benefit, manager in China. We're providing all the innovative payment solutions to people to the consumers and to patients to help them address their affordability issues in healthcare. Actually, in the past, several years, we have been serving in China over 100 million people under our, innovative payment solutions, and including those innovative health insurance, product, covering, and also addressing, last year, we think, we help over, 10 billion RMB, payments as a value size, to help the patient to pay for their medical bills. I look forward to this panel. Thank you.
Well, thank you all for being here. Amazing work that you're doing. And I'd like to start off with the first question. How has COVID-19 structurally changed patient, consumer, government demand for healthcare systems? Do we want to start with Viren?
Sure. Well, obviously, it made everyone just how aware of how fragile our healthcare systems are. And this is not just an EM phenomenon. I think even healthcare systems in the most advanced countries in the world suddenly realize that they don't simply have the capacity, whether it's beds, manpower, ventilators, monitors, nurses, doctors, to deal with if millions of people fall sick all at the same time. That was the most obvious learning. But from a more granular aspect of what happened on the day-to-day, we've been running telemedicine in our organization since 2004. Starting out with VSAT connections and dial-up and Skype. And there really wasn't, I would say, a tremendous push that was coming either from doctors or patients. The one thing everyone says about the pandemic, it's been this great accelerant, which is behaviors that seemed little too much in the future, or behaviors like ordering medicines online, getting consultations online, consulting with your doctors without having to physically visit a hospital. The adoption curve for that just took this massive spike upwards. And so overnight, we started to see that our outpatient numbers that happen online went from 200, 300 a day to a few thousand a day. And it has tapered off a lot since the pandemic has ended, but there is this persistence in the behavior. And we believe that as responsible healthcare providers for the next century, we have to be able to start delivering a lot more healthcare to patients wherever they are. It cannot entirely be centered around them visiting our hospitals, clinics, or physically meeting our doctors. And so for that, we've had to really adopt a lot of the newer business model that have been pioneered by startups in the area and use that to change a lot of the working practices of hospitals that otherwise tend to be quite inefficient.
Thank you, Viren. Snehal, you would like to add anything?
Yeah, absolutely. I think there's probably two big trends that we've noticed, or we've noticed in Southeast Asia in general, that I think are pretty noteworthy that have come about because of COVID-19. The first is actually I think Vera made a good point about how it has been an accelerant. And on a granular level, we've obviously seen the large spikes in demand, and I think overall, I guess, consumer acceptance of telemedicine. But I think what was more notable was that, like in countries where you see this huge accelerant in acceptance at the government level. I'll give you an example. There was a remarkable moment in, I believe, several months ago when Indonesia was going through a specific spike. And the government basically co-opted or essentially deputized all of the private telemedicine providers to become essentially a national triaging agent. And that was a huge moment. If you think about how typically the challenges we have in digital health is, you need government support, you need to be able to integrate work with government hospitals, et cetera, but it takes a long time. Overnight, literally the government said, do not come to the hospitals, be triaged using these digital tools, we'll pay for it, and then the patients can go to a public hospital if they are severe enough. So I think that was a huge step. The second thing that I thought was really remarkable, also related to how governments have been interacting with some of the more innovative players in the market. Here in Singapore, when there was a spike in COVID use, the government again sort of went to the public and said, we're going to turn everyone's bedrooms into hospital rooms. So this idea of hospital to home has been around for a long time, but that literally happened. So what happened was that the protocol was patients were then actually they were encouraged to, if they tested positive on a rapid test, they were to sort of self-sequester for 3 to 5 days, and then they would use telemedicine to connect with the healthcare facilities. That was remarkable. I mean, because if you think about all the challenges we've had over the decades of trying to shift from acute care to chronic care, from episodic care to sort of continuous care, it happened overnight. And I think those two shifts are not going away. And, you know, post-pandemic, they're going to be repurposed for other things that I think are much more long-term and long-lasting, like the chronic disease crisis we have across the region.
Snehal, it's great to hear those examples from Singapore and Indonesia as well. So, Keith, do you have anything else to add?
Yeah, I mean, really very similar observations from the previous two, as you would expect from Bangladesh. I mean, what we did observe very clearly was the change in consumer and patient behaviours, and really the willingness to adopt digital health as the primary route into healthcare system. I've worked in digital health in Bangladesh for nearly 10 years, and behavioural change was always the biggest challenge. There was a distrust of services like that, and I saw more behavioural change in the last 2 years that I'd seen kind of aggregated over the previous 8 years combined. And we saw, you know, demand skyrocket for those types of services, which really forced us to be agile and prepone the launch of, you know, a range of digital services. And just to give you an example, prior to COVID, you know, virtual consults constituted about 5% of our overall mix. That obviously shot up through the pandemic, but you know, it's holding steady at about 30% of all of our consults are now virtual. So it looks like those patients that had one or two initial virtual consults, it seems the trust is there and the stickiness is there for those kind of services. So we very much see this being the new normal moving forward. One other thing that does really spring out loud and clear from Bangladesh and from patients, and particularly the new health seekers, is this need for kind of quality healthcare in a place like Bangladesh, where more people were dying from a lack of access to quality healthcare rather than access alone. I think COVID with it has brought with it kind of a change of mindset of a typical health seeker and consumer, where quality is one of those factors that is top of mind when selecting a healthcare provider. So I think those are probably, I mean, I agree with everything that's been said up until now, but I think those are the 2 points that I would add on top.
Great, thank you, Keith. Seth, I'll be really interested to hear how you're seeing it from a health benefit and payer standpoint as well.
Yeah, thank you. You know, actually, you know, right now I'm in China. You know, China right now is also experiencing another outbreak of COVID right now. So I think, you know, if you look back in the past like 2 years, you know, with all this COVID, and also even if you look before the COVID, I think the consumers in China has been changed as you know, the previous guest has been mentioned. Actually, the openness and you know, we are more acceptable for the telemedicine and you know, for those virtual consultation, all those kind of things. You know, from my observation, especially, you know, we are addressing the payment issues. You know, I think the COVID totally changed the mindset of, for example, if you are sick, you know, whether you should pay for your health by yourself, or it should be the government, or it should be the commercial insurance, right? Because, you know, the payer is a very tricky part in the entire healthcare system. You know, for example, in China, 50% of the entire healthcare expenses are paid by the government, which is in China social insurance. You know, there's another 45% paid out of pocket, only 5% paid by the commercial insurance. I think that number has been not dramatically changed yet, but you know, there's many. The direction is that people are willing to pay for their healthcare, you know, by themselves, but not directly. You know, for example, pay for the medical bills. But you know, that's the reason why we kind of introduce this kind of innovative health insurance side to China. Because just imagine, before this, you know, 2020, the majority of so-called commercial health insurance market is mainly in US, right? So US is the only kind of the largest, you know, commercial insurance market. But right now in China, you know, hundreds of million people right now are covered under the commercial insurance. For that part, especially after the COVID, people are willing to pay for their, you know, private commercial insurance by themselves, on top of the social insurance, because every month, you know, the government also want to charge part of that, you know, into this social insurance fund. So that also can somehow address, you know, some of the issues of after this COVID. For example, how, you know, who gonna pay for those telemedicines, right? Who gonna pay for those, access to the quality care. Because if you rely on the government or rely on social insurance, that will be access to care, right? Probably access to health. But if you leverage those innovative payers, like all those innovative commercial insurance payers, that also give access to the general population. They can afford those kind of private or higher quality of care. So this is something dramatically changed in China in the last 2 years. Thank you.
Seth, thank you. I can't believe only 5% commercial insurance. So different from where we are in the U.S. Another question to all of you. How are the new business models, reinventions, addressing their demands and incorporating inclusive healthcare elements? I'll open up to whoever would like to answer first.
I can start. Seth raised a very important point on access to payment. You cannot decouple access to healthcare from the ability to pay for healthcare at all. And with EMs, this is not really a solved problem. Even if you were to go under the assumption that the government as a single payer will take care of the healthcare expenses, our economies aren't as big and as strong to be able to take care of the healthcare needs of the entire country. So there has to be some component of private payment, individual participation, as well as large health systems working in a more integrated fashion. We're still in the early stages of this, but we're starting to see a lot more interest in hospitals, clinics, startups working together to create these kinds of virtual care teams, to create alliances, to work with insurance companies so that we start crafting solutions that are more tailored to the whole health of the patient. Whereas right now, in most EM countries, healthcare is episodic. It's episodic, it is fee for service, and you only think about it at the time you're falling sick. And so what does that mean? Well, that means you have a healthcare system that's built only for edge case scenarios, right? It is the most common thing in India for a person in his 50s to come to the doctor having had a heart attack and say, "Doc, this is the first time I'm visiting a hospital. I've never had to see a doctor my whole life. I've been absolutely fine." But that's one way to think about it, and he takes it as a point of pride. But from the healthcare system's perspective, no, you actually should have gotten a checkup done in your 40s. We should have done a CT scan on you. You're Indian, you're genetically 3 times more vulnerable to heart disease than most other populations. And so without spending a penny on screening and preventive care, we're now spending you're spending pounds on getting operated for your heart attack. And so I would see the big shift coming from a population health management standpoint, from working towards preventative care and from having people access healthcare more, means they need to start getting more healthcare. The one thing is that, so I'll make this last point, that in India at least, we are the most under-medicated, under-diagnosed, under-health provisions population in the world. So it's not that we don't spend enough on healthcare, it's just that not enough of it is available. And so the only healthcare people end up getting is extreme, which is just surgeries and procedures. And you cannot build a healthcare system built entirely around very expensive procedures. There has to be a lot more done in the preventative side, in screening, and in making sure that people get tested remotely or in diagnostic centers and take medicines to make sure that it doesn't end up being very serious for them.
Seth, thank you. Go ahead.
Maybe I will just jump in on, I think Viren made a couple of really important points. And I think this is something I typically emphasize when I have these conversations with folks that are not usual sort of healthcare insiders. There's I think a misnomer that people think that, even in tech, you can make healthcare sexy, for lack of a better term, right? The reality is, I think Viren's right. No one will ever make healthcare sexy. The reality is, human beings are not not designed to like to think about mortality. They don't like to think about sickness, because sickness leads to mortality. And that's hardwired into what we do. And so I think what we need to do, and it's sort of on these same points, in order to get preventative care, everyone has known preventative care is the right way to go about managing patients for decades. The problem is adoption has been very poor for the reasons I just mentioned. And I think the difference now is 2 things. One is we now have technology tools to make that the friction points, if you want to use consumer, sort of consumer grade conversation or sort of terminology, much lower. In fact, healthcare should be invisible. I think the proper care modules, once properly designed, will become so friction-free that in general, patients don't have to think about these uncomfortable thoughts because it's being done in the background. And I think secondly, associated, connected to that is the shift, again, Viren mentioned fee for service. The reality is, I think in this region, it's only now our government's catching on to the fact that their systems are no longer sustainable. I use Singapore as a great example. There's been many, many articles, many books written about how in the OECD, Singapore has fantastic world-beating outcomes at a fraction of the OECD cost. Well, the budget here has expanded, has doubled in the last 2 years. And now even Singapore is going to be grappling with the hangover, if you will, of a fee-for-service model. But the good thing, again, is technology is here to help solve that issue. And it is integrative care. It's bringing together preventative care, primary care, secondary care, tertiary care, but using a invisible layer with technology to help make those experiences more friction-free, much more seamless. And I think you'll start to see far greater utilization and adherence as a result.
Yeah, and I won't repeat what both the panelists have said. I agree entirely. I mean, I will speak from a Praava and Bangladesh context, just to the question of feasibility of scale. I mean, one thing that we've seen with launching, these digital services and this technology layer, we've been able to prepone and get out to tier 2, tier 3 cities, probably 4 or 5 years ahead of where we'd actually envisaged to be. So we really think leveraging up, and I think for us, COVID was somewhat a validator for our initial hypothesis and the business model to own part of the bricks and mortar value chain and to put this kind of virtual layer on top. And really it's kind of preponed us and our vision really to get quality, affordable healthcare out to the entire 180 million people potentially that reside in Bangladesh, and all the constraints that we had both financially, logistically to do that. I think somewhat that friction has been released, and if you overlay the behavioral change on top of that, I mean, that really is a pincer movement to the adoption of these kind of business models that will allow us to scale. So that would be kind of the piece that I would add on top.
And Seth, any points too to add?
Yes, actually, I very much agree with Viren just mentioned that you can never separate the access to health and also the affordability, right? Because actually, for example, in China right now, in the past several years, actually the Chinese government has changed the regulations of how you get access to China. For example, right now you almost can get all those your advanced therapies, new medications to China very easily. There's no barriers that you cannot bring the global, the top-notch, medication to China. But the key issue is that even you bring those medications to China, whether the Chinese people can afford that, and also whether the social insurance going to pay for that. For example, we are working with one of the largest, pharmaceutical companies globally, and looking at their rare disease medication, which is, in US, is almost like $2 million USD per therapy. But can you imagine that the social insurance can never pay for that? But whether can the private insurance pay for that? That would require a pure new kind of design of whether Chinese this private insurance. And another very interesting thing is about all folks just mentioned about the value-based healthcare. I think, for example, in China, we invent this kind of new insurance, new type of health insurance for those, for example, the patient who use CAR T, right? In China, the CAR T therapy is around $200,000 US per therapy, which can cure your disease. But there's still a chance that you pay for 200K, but you still can not get cured out of pocket. That is huge money for the people here. So we're working with the health insurance companies, we give this insurance to say, if you do not get cured, the insurance company is going to pay back all the entire kind of payment of these medications. And that kind of insurance is we cooperate with pharmaceutical companies directly. So these type of new solutions of the payment that totally change how people pay for their health, and also how does this new and also high quality healthcare therapies, medications can come to China, get access. Thank you.
Seth, so interesting, that the kind of partnership with pharma and paying it back if there's not a cure. So thank you so much for sharing it. Any last thoughts on that before we go into the next question? If not, then our final question, because we only have a few minutes left, is how feasible is it to scale these business models? What's your general view of the growth, profitability, cost structures during this process? Open up to all the panelists.
Yeah, I think at scaling, you've hit absolutely the nail on the head. I mean, on a theoretical construct level, these things make all the sense in the world. Trying to move people away from episodic care towards more preventative, for healthcare systems to start working closely with insurance companies, for government to start trusting the private healthcare providers more, for insurance companies to start trusting the prescription behavior of doctors. There are a lot of embedded assumptions built in to a fee-for-service model. The assumption being that on the one hand, a provider is trying to maximize the amount of treatment that's possible. And from a payer side, they're trying to minimize the payout that's going to happen. That's one aspect of that. Snehal had mentioned earlier about how patients just aren't aligned around taking things proactively. So other than the annual health checkup, which I think some corporates are quite enlightened about enforcing on their employees, that accounts for a very small percentage of the overall population of a country. It doesn't account for most women who aren't working. It doesn't account for taxi drivers, daily wage people, and people in the informal sector who really don't have this push to get themselves screened for cancer until it's too late, to get their CT scans done on their on the heart so that they can check for blockages. The other thing about working with startups also is a question of where the responsibility lies. So on the one hand, there could be one agency that's responsible for a lot of the primary care screening, but then they always, there's a sense that they want to maintain patients within that network. Whereas maybe 1 in 10 people with a heart blockage could better be managed with a stent rather than through medication. And so that means moving a patient from one small narrow network to another narrow network. And then it becomes a massive coordination challenge because when a patient then enters let's say a hospital network, moved out of a clinic network, there's very little chance that they will end up going back. And so it's a combination of a massive coordination problem, a lot of trust, and the fact that the incentives right now are not aligned around the patient. The incentives are aligned entirely around doing procedures and getting paid for them or not getting paid for them. And I think that would be one of the big challenges going forward.
Yeah, I'll just quickly add to that. I think Viren hit most of the key pertinent issues on the head. But I would sort of say that I think in addition, one of the challenges that we see, and I do this in contrast to our colleagues in faster growing tech parts of the ecosystem. You know, my fintech friend says, well, we can grow at 15 times a year. And I'm like, well, we don't do that in healthcare. That's not what we do. And, you know, I think the reality is the system is, as Viren correctly pointed out, we've just got multiple stakeholders, and this balance of power, this sort of tension that's between the various Ps, the patient, the provider, the payer, it sort of creates a decent balance, but it needs to shift in a value-based care sort of world. Now, I think though, from a first principles basis, and I think this is where my optimism comes from, we're kind of in a situation where there's no choice, right? So it's whenever, you know, necessity is a mother of invention, and the reality is the budget simply can't sustain the cost that all the governments, all insurers are sustaining currently, or they're sort of having hit their balance sheets. As a result, that something will change, and that change is coming, and you're seeing it already being rolled around the region.
We know we're coming up close to time. So any other last words of advice in this area on this question? No, Seth or?
Yeah, I think, you know, yeah, just very last words. Yeah, actually, we just, you know, I think before the COVID, we already set the company in Singapore. So actually, you know, we believe that not only in China, you know, the entire Southeast Asia, but also probably 90% of the globally, 90% of the population needs this kind of new type of, you know, payment solutions instead of, you know, there's a very mature commercial insurance other than US, right? So I think, you know, looking forward to continuing this dialogue with all the folks here, and probably we can cooperate somewhere.
Wonderful. Thank you so much. And Keith, do you want to close us out with any of your last thoughts?
Yeah, I mean, I guess just final thoughts from me. I mean, we're talking about scaling and growth, and one of our key challenges is how you maintain quality going through that kind of curve and that kind of adoption as quickly as we've seen it in a place like Bangladesh, where the plethora of doctors just isn't there. It's really forced us to look at innovative technology solutions. We were looking at things like CDSs because they were interesting a couple of years ago. We're now looking at that layer of technology because we have to look to maintain that level of quality as we scale the business. So that would be the only point I would add. Thank you so much.
Great. Well, thank you so much to all of you for sharing kind of your insights, your wonderful programs, businesses, the impacts that you're having across millions as well. So thank you all for being here. I'm going to turn it over to the organizers of the conference.